At the outside, I thank Dr. L.K. Prashant, who has been my friend, philosopher, and guide for past 2 decades. So I am not a movement disorder specialist, but I have been administering Botox since almost now 18 years. So I am not even an academician now of late because I am into busy private practice. So I would apologize you because if my talk is not that good, because L.K. Prashant told me, come to Bangalore, let us have a fellowship, let us have a get-together. And last minute I realized that I was the speaker. So I really thank him to backstabbing me and putting on the stage today.
He's a really good friend.
So that is how it is. But I do have quite amount of experience in giving Botox, even for those so-called off-label indications. I often use a lot. So here am I. I think most of the things have been covered by Dr. Ajit. So he has also sort of encroached into the topic, and he has told so many things about what I'm already supposed to say. I will just brief few slides to show. I have not got any videos. But for the beginners, I'll be really happy if you approach me later. I'll be able to send any videos or any material which is needed for you to learn. You can just approach me later on after the talk. So I do have videos with me, so I can give it to you by email, or I can send it to you by a pen drive or something, or through the Zorbot representatives. So this Dr. Ajit has already covered. So how does the botulinum toxin work? So it basically works on the synapse, and it basically acts on the SNAP25 proteins and prevents the fusion of the acetylcholine into the membrane, and it does a sort of a chemo denervation of the nerve. I think the sir has shown a very beautiful video, and all of you have seen that. Now we do not know why sort of FDA really hates Botox, because this is how FDA approval started. I think way back in 1973, I think Dr. Scott showed that it was effective for strabismus. Then onwards, maybe in the first time in 1989, I think FDA approved for strabismus, blepharospasm, and hemifacial spasm in 1989. And in 2000, it approved for cervical dystonia. And in 2002, it approved for cosmetic use in the glabellar lines. The glabellar lines are nothing but the frown lines you see when you are angry. So, but it took them almost 10 years to approve for the lateral canthal lines. Now, it is quite amusing that why it took almost 10 years from an angry glabellar line to the crow's feet, which is seen in the lateral part. That is a cosmetic use. I think somebody is going to talk on that also today. Then 2004, it was used for approved for axillary hyperhidrosis, which there is sweating of in the axilla. Then onwards, 2010 and 2011, there were a lot of approvals for spasticity, especially for post-stroke spasticity and traumatic brain injury, multiple sclerosis associated spasticity. 2010, it was for chronic migraine. And chronic migraine is the only condition, pain disorder, which has been sort of FDA approved. So other conditions like post-herpetic neuralgia or the post-CP pain syndromes, they are not approved. They are all sort of off-label. Then 2011 was the last one where they approved for overactive bladder. And I think in 2015-19, they have approved other brands, like other than the onabotulinum, they have approved the other botulinums, but there are no new indications for approval after 2015. How many people who are there, residents or students are there? Can you raise your hands? Quite a lot. So there are a lot of botulinum toxin preparations, onabotulinum, abobotulinum. I think Ajit sir has already told about each and advantages of each. The incobotulinum is supposed to be the purest. And the last one which he mentioned, I think, what was it, sir? The one which acts for 6 months. Yeah, that is supposed to be acts to about 6 to 7 months. That's been recently approved for cervical dystonia alone. Now, it will be a little boring for me to just read out the slide here, but and I think all these individual conditions The experts will be talking. So I will not go into depth about cervical dystonia, the nuances of it, about caput and collis, how to assess a caput collis. Everything will be covered in later on session. Blepharospasms, sir has already mentioned. So usually we use around 50 units of botulinum toxin, and predominantly injection will be given to the pretarsal plate. Now coming to the laryngeal dystonia, I think we will not be covering that, but I do have very beautiful videos. Last year we had conducted a one-day CME on laryngeal dystonia. I think some of you from Bangalore had attended that. I do have videos of that. I can give it to you if you approach me. So laryngeal dystonia, it is otherwise called as a spasmodic dystonia. We have got an adductor type and abductor type, and it is given with a EMG needle by first instilling a 0.5 ml of lignocaine into the cricothyroid membrane, followed by giving about 1 to 2 units of Botox to the adductor or abductor muscles. In other way, you can also approach transorally via endoscopic also. Usually you have to take a help of a ENT person to do that. Then task-specific dystonia, sir was mentioning about the writer's cramps. Again, I think with Dr. Gopal, we had a lot of deliberation how to approach a patient of limb-specific dystonia, but my topic is not about that. We can cover it during the tea break also. Then orolingual and oromandibular, I think they are covering today. Then coming to the spasticity, it is since 2010 it has been approved for upper limb spasticity as well as the lower limb spasticity. Basically, the assessment matters here. So what kind of what muscles are spastic, whether it is the palm in thumb, hand in thumb deformity, or which are the muscles which are basically spastic. And based on your assessment, you have to decide the dose. And the dose also will vary from muscle to muscle. The larger muscles like hamstring itself will take around 150 to 200 units, whereas the small hand muscles will take maybe a few units like 10 or 20 units. The forearm muscles like a pronator teres or FDS will take around 10 to 40 units. Then the Botox in otolaryngally, one I had already told, spasmodic dystonia. The other one interesting of late I have found is in the lateral medial syndromes. So in past decade, I have done cricopharyngeal myotomy for about 4 or 5 patients. These patients were moving on a Riles tube for 5 months, 6 months, and one patient from Singapore almost for 2 years. So after doing the myotomy, the dysphagia improves. But before doing the surgery, the counterpart of that is Botox, where you give the Botox to the cricopharyngeus muscle. So it really helps, and I can share the material later on with you. Now, first before that, we have to do a proper barium swallow, and we have to assess that there is a cricopharyngeal muscle dysfunction in these patients, which directs the food into the trachea. So if you demonstrate that and that there is an aspiration directly when the patient is swallowing, then we can give the cricopharyngeal muscle Botox injections. Around 20 to 30 units should be sufficient. And beautifully after 1 week, they start swallowing. I had the patient who had lost weight and he was just 35 kilos. And after 1 year of Botox, his weight dramatically improved almost to 73 kilos. So he is the one person who is still wishes me on doctor's days. So then we also have non-dystonic disorders of the involuntary muscle activity. They are like hemifacial spasms, then tremors. So we have neck tremors as well as the hand tremors. The commonest neck tremors we have is a SS and a no-no tremors. The no-no tremors is in the horizontal plane, and in the SS tremors is predominantly in the sagittal plane. As you all know, that SS tremors is predominantly due to sternocleidomastoid, and the no-no tremors are predominantly due to semispinalitis. So if you target the Botox, we can achieve that. Similarly, when you see the tremors, we have to see all the components, whether the fingers are moving, whether the wrists are moving, whether there is a pronation supination movement, and whether there is any proximal movement. If it is predominantly wrist movement, like in most of the tremors, then giving Botox for botulinum toxin for flexor carpi radialis, ulnaris, extensor carpi radialis, ulnaris will suffice. So that similarly, if other muscles are involved, if the pronators are involved, then we'll have to give to the pronators also, like pronator teres and pronator quadratus. Then tics, I think sir showed a video of ocular tics. So that is also one indication, but many of them do respond to do respond to medicines also. The patients who don't respond to medications, especially the one which you call as a whiplash tics, where there is a violent extension of the neck, which is called as a whiplash tics, and that can cause cervical injury also. In those kind of tics, especially by injecting botulinum toxin into bilateral semispinalis, it helps a lot. Then the other one is myokymia. I think sir showed a video of myokymia also. And tinnitus, some people have developed refractory tinnitus due to the spasm of the stapedius muscles. By injecting into the stapedius muscles, we can relieve tinnitus, even though I have not done such cases. Hereditary muscle cramps, if there is very few focal muscles which are involved causing muscle cramps, we can inject botulinum toxin there. Nocturnal bruxism, which are very refractory, again, trismus and anismus. Then coming to the pain, so the only approved is the migraine, and other pain due to like trigeminal neuralgia and post-herpetic neuralgia also give wonderful response when botulinum toxin is injected. So here again we have to draw boxes in the area involved, and we have to give intracutaneous injections of botulinum toxin into these areas. Lateral epicondylitis or the tennis elbow, which is very, very common among your patients. I think every week you will be seeing so many patients. Some of them are very, very refractory. So giving botulinum toxin about 20 units or 30 units into epicondylitis, which are very refractory to all sorts of medical management, will really help. And maybe I have given about 3 or 4 cases till now. Then smooth muscle hyperactive disorders, detrusor hyperreflexia or detrusor dyssynergia. Again, it is given in patients who develop neurogenic bladder post multiple sclerosis or traumatic brain injury. Again, there will be incontinence or urge incontinence. Here again, the Botox will be given with the help of a cystoscope. So I usually team up with our urologists, and we have about 8 or 10 cases so far. We have done cases. Then achalasia cardia, which is again spasm of esophagus, even though I don't have much experience in treating that disease. Hirschsprung's disease, anal fissure, and even Raynaud's phenomenon. Then cosmetic use, I will skip these slides. Then coming to the sweating and salivary gland and allergy. The sweating, the ones which are troublesome are in the axillary and in the palmar hyperhidrosis. The axillary ones the people usually tolerate, but the palmar hyperhidrosis is quite common in young students who are studying in their board exams or 12th exams. They do come at the time of exams, and again it is intradermal injections by giving local anesthetic cream and then giving multiple doses in a square like box. We mark the boxes and give intradermally this one. It really helps them, especially during the time of exams. Frey's syndrome is again sweating after a parotid gland surgery, where they sweat over the skin covering the parotid area. Again, it is very, very useful. Drooling, I think again all of you would have seen CP patients drooling in your OPD or an MND patient drooling in your OPD. So it really helps, especially to parotid. 30 units of botulinum toxin to each parotid gland again helps here. And what I found is most useful is, because I am a neurologist and I see a lot of stroke patients, most of our large MCA patient strokes lying in the bed aspirating, it really helps in these kind of patients when we give Botox in these patients, and it really saves many tracheostomies. So I think most of neurologists among you should consider this in a large MCA stroke who is very, very moribund or bedridden. Then nasal allergy, I have heard giving Botox into the inferior turbinate, where it really helps. I don't know, I have not tried it. Now, unusual indications are also there. Depression. Can anybody tell me how Botox helps in depression? All are sleeping. Obviously, I am a boring speaker, but I can ask one question to you. So basically, you identify what muscles are causing sadness, sad expression, like me. So identify those sad muscles and give Botox to botulinum toxin. Sorry, Gufik, for telling Botox, because I've been telling for past 2 decades. Okay. So if you give to those sad muscles, you can, sort of reduce the depression. Maybe LK Prashant's anger we can reduce by giving botulinum toxin to his corrugated supercilii also. He ran away from here. Other things are myofascial pain syndromes. I don't know whether they really work. I have not given, but they're very common. But most of them do respond to medications, counseling. Some of them are very, very refractory. Maybe we can try on those patients. Vaginismus, TMJ disorders, chronic pancreatitis, and some brain, all those conditions I don't have experience, but I do have few experience with cerebral palsy. I think people who treat with cerebral palsy, they do develop severe pain in the lower limbs, so refractory pains that even 300 milligram of pregabalin or oxcarbazepine doesn't reduce the pain. So in those cases, if you carefully identify which muscles are really spastic and the area which is involved, and botulinum toxin have really helped in those kind of patients. So I think that's the end of the talk. Thank you for patient listening. So if any newcomers or youngsters who want to learn the technique, especially for cricopharyngeus muscles or the spasmodic dysphonia, or for that matter, piriformis syndrome, that is also a very common syndrome. We have used about 8 to 10 cases till now. They present with a typical sciatic pain, and your MRI is normal, basically. And when you do test for piriformis stretching, they are strongly positive. It is the piriformis muscle which is compressing the nerve. They roam around, people, everybody telling them disc. There may be a very small disc, and some people have undergone surgery also, and without no benefit. In such patients, injection into the piriformis muscle, it is done with a LP needle under a CIAM guidance. We have done around 8 to 10 cases. They also give it. I have the materials. If somebody is interested, I am ready to give you. Thank you very much. And